Now we have placed a 12-lead EKG leads on the patient. You see that my defibrillator pads are here, and this looks really busy on the patient's chest. If this were a woman, this would actually look even more busy, because if you think about it, we should avoid placing a pad or paddle on a woman's breast, because that will prevent the electricity from getting to the myocardium. So normally a placement of the pad for a woman would be under the breast, as close as you can get to the heart's apex, but normally will go kind of on the lateral axillary line in the 5th or 6th intercostal, and then you would also have to slightly adjust the placement of your 12-lead EKG. So now I'm getting ready to defibrillate. In the meantime, my RT arrived, because this is something that you would call, somebody who you would call in the code. The RT would have placed 100% oxygen on my patient, or one of my colleagues could have done that as well. Now, if the patient is not breathing, the RT would be giving the patient breaths with an ambu bag and thinking about securing an airway. And now this is a team effort, and definitely a dance where we try to optimize the outcome for the patient. We need to restore their cardiac output, but we also need to make sure that they're getting oxygen. So in between my CPR, placement of all the electrodes and pads, defibrillation, we also need to be thinking about whether or not this patient needs to be intubated, and we would need to fit intubation into our patient's care in between defibrillation and all the other interventions. So I'm getting ready to defibrillate. My last check is that I look at the monitor and I make sure that the patient is still in a rhythm that is indeed defibrillatable. Pulseless VTAC or ventricular fibrillation. My patient is still in course ventricular fibrillation. At this point, myself and the doctor will proceed to defibrillate the patient. If I am the nurse who is taking care of the defibrillator, I will obviously position myself near the defibrillator. I will make sure that I can see the monitor, the cardiac monitor of the patient, and I will also make sure that I have access to check the patient's pulse, so either access to his carotid pulse or femoral pulse or brachial pulse. I am ready to defibrillate, so what I'm going to ask the doctor now is, what is the charge that you want me to put on the defibrillator? And normally for a biphasic defibrillator, you can start with 120 and progress all the way up to 200 joules. This is really physician's choice, and you will see that in different situations, your physician will advise you of different charges to defibrillate at, but normally we would start at 120 joules. What I'm going to do now is I am going to turn on my defibrillator. I will turn this knob all the way to defibrillate. I will wait for the monitor to turn on. Okay. You will see that defibrillate 120 joules is already selected. If my physician told me I want you to defibrillate at 200 joules right away, I can change my joules here by using the button selection of energy, and I can press up all the way to 200. Okay, I will keep it at 120 joules right now. One little check that needs to be done before I press the button to defibrillate my patient is the RT or whoever is at the head of the patient taking care of their oxygen and respirations. They need to turn off the oxygen source, because the open oxygen near a patient is actually a risk for combustion. So once that is done, I can proceed with my clear check and defibrillation. The clear check is when I make sure that there's nobody beside, well, people can be beside the patient, but nobody's touching the patient. And I also have to make sure that the source of oxygen is disconnected just for the time of defibrillation. So I will say, I'm clear, you're clear, everybody's clear. I'm checking that nobody's touching the patient. And then I'll go back, charge. And I will press shock. So now if we look on the monitor, what's going to happen when you press shock is you will see a big spike and then a period of no cardiac activity, so a period of asystole on the monitor that shouldn't last long. If you see that the asystole is continued, you will need to start CPR right away. In general, when you have given a shock to a patient, You should not be immediately looking to the monitor. You should not be checking for a pulse. What you do is you go back and you continue with CPR on the patient for 5 full cycles or 2 minutes. And this is the recommendation by Advanced Cardiac Life Support Guidelines. And only after the 2 minutes can you look at the monitor and do a pulse check. And then if you find that on the monitor your patient is still in a rhythm that needs to be defibrillated and that your patient has no pulse, you proceed with ACLS recommended interventions. So we just saw a defibrillation shock delivered to a patient with coarse ventricular fibrillation, and we will just show you on the monitor what happens if a patient is in fine ventricular fibrillation and what happens when a shock is delivered. If you are looking at the monitor now, fine ventricular fibrillation has a much lower amplitude. It looks like a scribble. So we will look now at what happens when a shock delivered to a fine ventricular fibrillation. So you see a small electricity spike and then a brief period of asystole. And unfortunately, this patient went back to fine ventricular fibrillation. So what I would do in this case is proceed with 2 minutes of CPR and then do my pulse check.